organizing this CME over here in Begusarai, Dr. Nishika, our chief. So lots of wonderful words have been said about these brilliant people. I just adding on to that, like Dr. Nishika was recently representing India. Out of 5 people who represented India in Switzerland, he was one of them who was representing India in the field of martial arts. And that really deserves a big round of applause. The less, the more we say, the less it would be regarding Dr. Saurabh Chaudhary. Again, I keep on saying, if you have ever witnessed him operating, you will feel as if you are witnessing a musician playing his musical instrument. That is the kind of study that he performed. Dr. Gurudev, again, an inspirational character that he is. Till the age of 8, he hadn't even seen the face of a school. And today, one of his chapters features only by his name in his Springer's books. The scenario of multi-ligament surgery in second-tier cities of India. The author is Dr. Gurudev Kumar. And I feel privileged to be a part of such a wonderful team working with these people, keep on learning and trying to implicate such things and passing on the benefits to my patients as well. So, lateral surgery is something which I believe most of the orthopedic surgeons they are performing. But this is pretty close to my heart for the simple reason that way back, I believe 8 to 10 years ago, I was attending a CME and a very renowned orthopedic surgeon was conducting that CME, and amongst the 50 people present in the hall, he asked who operates lateral surgery, and fortunately I was the only person in that hall at that time present who was doing lateral surgery. That is the reason. It still remains very close to my heart, although lots of changes have come in and people like Dr. Gurudev have taken over the arthroscopic way to deal with shoulder instability in such cases. So I'll keep it very crisp, very short. Only 2 take-home messages would be there. All of us know that lateral surgeries are being performed for recurrent dislocations of shoulders, right? So just adding on to that, one more indication that is also being done to prevent recurrent dislocation shoulders in cases of trauma. In late presenting cases of fracture dislocations of shoulders, you need a thoracoid osteotomy so that you can reach up to the head and you can keep it in place and then go about fixing it nicely. And then to prevent further dislocations, instead of putting back that thoracoid piece with the help of a single screw back to its naked position, you can use it as a graft on anterior inferior glenoid ribs and convert it into a lateral surgery so that no more further dislocations occur. And the second take-home message would be a sort of an innovation, I would say. At the time when I was learning this surgery, I was looking for some device as to how I could hold on to this piece of thoracoid graft so that I can get my screws to it in a safe and secure way over the anterior inferior glenoid rim. And I'll be sharing as to how I go about it. So indications remain therapeutic in cases of recurrent dislocations and prophylactic in cases of trauma, as I just discussed. So this was again a case of a recurrent dislocation of the shoulder, wherein it shows the post-op picture as well. This is fracture dislocation. Herein again, if you look carefully, you can see that there are 2 screws over the glenoid rim, and we use the glenoid piece osteotomy to get a reduction and then put it over the glenoid rim and converted it into a vanguard. It was again beautifully executed by my dear friend Dr. Gurudev. The others, I'll just give a passing mention to the slides. Nothing new. The surface marking with regards to the surgery by better pectoral approach is the routine one. This is how we harvest the thoracoid graft and then the subscat split in the horizontal plane, then inside the capsule of the shoulder vertically and reach the glenoid, and then repairing the fit of the glenoid rim as well as the undersurface of the graft. I didn't have access to the high school goals at that time. This is the way I used to prepare the undersurface of the graft, and then you go on to decorticate the graft and put it in place. And then, this is what I was discussing about. What I do is hold the graft with the head of a cockles or an Alice forceps, and then put it over the hole at the end of the rear end of a woman's retractor, and then pass 1 mm KYs through it, just flush to the opposite cortex. And then I can use these KYs as a joystick as well, so that I can place them, because the most the most difficult part of this surgery is placing the graft over the glenoid rim. So using these two KYs, we can place it on the anterior glenoid rim, or also just maintaining the grip with the cockles or the Alice. We can go ahead placing the graft over the glenoid rim, and then the remaining surgical steps become pretty much routine and easy for every orthopedic surgeon. So fixing the graft to the glenoid and then putting, I use cancellous cannulated screws, 34 mm, whatever the size comes, and then this is the final outcome, wherein the conjoint tendon acts as a sling, preventing the dislocation. Also, the graft, which effectively increases the surface of the glenoid cavity, preventing dislocations. The routine closures and the range of motion in this recurrent dislocation from the patient at 8 weeks, and this is my wonderful team. Thank you so much.